Welcome to the Westport Library. Today's program will begin momentarily. Supported by Verso Studios, created locally and shared with the world.
Oh, hello, Westport. Come on, you can do better than that. Thank you, that's much better. So I'm here tonight to talk about my favorite stuffing recipe. These are the jokes. Good evening and welcome, my fellow Warsporters, to our Westport Worrywart Club. I'm Andrew Wilk. I'm a trustee of the library. I'm very, very happy to be here. And I'm equally proud to say that this community has embraced this medical series, and I'm thrilled about that. Dr. Robert Altbaum has brought his incredible expertise and his colleagues to bear to teach us about the medical issues of the day. As you know, we've done 3 parts on cardiac care and 3 parts now on the brain. This is the final evening. We're going to continue the series into next year. We're planning a series of lectures, multi-part series on mental health, and also a series focusing on oncology. We'll be announcing dates soon, so we want you to join us next year, I hope. And if you have other ideas, please contact me or Alex Giannini here at the library, and we'll certainly consider those. Such a broad subject these days. Our goal, as always, is to provide the community with practical and up-to-date information on the subjects that impact all of our lives. Tonight is the 3rd and final series on the brain, final episode on the brain. We've covered strokes and TIAs and headaches in depth. Tonight's topic is one that's likely touched most everyone in this room in one way or another: dementia and Alzheimer's. Scary just at the sound of it. Joining Dr. Altbaum tonight is neurologist Dr. Michael Fitzpatrick. Dr. Fitzpatrick graduated from Texas Tech University and HSC School of Medicine in 2017. He completed his residency and fellowship training at Dartmouth Hitchcock Medical Series. Somehow that sounds scary with Hitchcock in there. I don't know what it is. I have sweaters older than this guy. You'll see. Yeah. Dr. Altbaum received his medical degree from Harvard University, completed his training at Mass General and Yale New Haven, and he continues to teach. And I have to say, the students that he has under him are very, very lucky to have Bob Altbaum. Equally so, if you've been a patient of Dr. Altbaum's. I couldn't even get in to see the guy when I moved to Westport, but we became friends afterward. Lucky him, afterward. So that is it for me, and now I want to welcome to the stage Bob Altbaum and Michael Fitzpatrick. They'll tell you more about my stuffing recipe.
Sit down. Now let's get back to where I want to be. There we go. I'm not sure why. There we go. Okay. Well, thank you all for coming out on this otherwise grisly night. I really appreciate the turnout. We're going to talk about a really important topic, which is dementia. Now, this is, again, as he said, the 3rd in the neurology series at the Westport Library. The idea of this series was conceived of by Andrew Wilk and has been very well supported by the library. So we thank you for coming out. Tonight we're going to talk about dementia, and an interesting thing, when they've asked the United States adult people who what they fear most, what is the disease they fear most, number 1 is cancer, but cancer is a lot of diseases. Number 2 is dementia, more than heart disease, more than lung disease, more than strokes, more than diabetes. It's an extremely frightening disease because basically what dementia does is it basically causes a persistent and progressive decline in your intellectual function that eventually disables you. And it does this in multiple different aspects of cognition. It does it in memory, it does it in language, it does it in behavior, it does it in problem solving. It's a progressive disease. And it's not really one disease, it's a syndrome. There are many things and many aspects of diseases that cause dementia as a syndrome, the decline in function. Often it starts years before you actually see somebody clinically. If you actually could do examinations of people's brains, 15 years earlier, they might show signs of early dementia, early signs that lead to dementia. And basically what it is a damage to small neurons that are involved in thinking, in problem solving, and those neurons don't connect well anymore, and they just stop working. Now, dementia is common. Dementia by the numbers, there are a lot of unfortunate people. There are 6 million people currently in the United States who suffer from dementia, and that's predicted to go more than double to 14 million by the year 2040. You do see it in people under the age of 65, 200,000 people, but as a general rule, it's a disease associated with aging. But it is not an inevitability of aging. In people over 90, about 30 to 40% of them may have signs of dementia. The majority still do not have dementia, and that's a very important concept for people to understand. Now, I mentioned that dementia has a lot of different aspects. There are different, what we call domains, different neurocognitive domains in thinking and function, memory, visual spatial relations, how people relate to their environment, people, how they problem solve, we call that executive function, how they plan, how they behave. Each one of these is an aspect of dementia. And you can kind of predict signs of dementia. There are far more than 10 signs of dementia. But if you think of each domain, you could easily predict. If memory, which is the most common we think of, and you start forgetting your keys, you misplace things. You might forget the names of your family. That's a little bit more serious. If you have problems with executive planning or function, something like a Thanksgiving dinner for your family of 8, which used to be a simple task for most people, is very daunting. You have to make up a menu. You have to go shop. You have to think how to set the table. You've got to basically cook the food. Something that was really routine suddenly becomes impossible. It can be very disabling. Mood can change, behavior can change. A very common sign of dementia is agitation. Another sign is apathy. People just aren't interested, and sometimes they can get depressed. So many different aspects of dementia are shown, although we all tend to think quickly of memory, there are many other parts of it. Now, there are really a lot of different causes of dementia. When we think of dementia, we tend to think of Alzheimer's, which still makes up the majority. And Alzheimer's disease is a protein disease, which is a neurodegenerative. It's a degeneration of the actual neurons in the brain. And there's also can be linked, 10% are Alzheimer's disease and another disease which is similar called Lewy body, which Dr. Fitzpatrick will probably elaborate on, and vascular disease, like small, almost infinitesimal strokes. But the one thing I really want to highlight here is the 6% of other. Unfortunately, when you look at dementia and you come to the doctor and he works it up, only 6 to 10% of those people have a truly reversible cause of dementia. And that's really a very disappointing thing. We do lots of testing, but most of the patients do not have a reversible cause. They have a degenerative cause, often due to abnormal proteins, different proteins that build up in cells and prove toxic to the cells and eventually prevent the cells from working normally. One other thing, just because dementia's got a lot of press recently, Lewy body dementia was the dementia that Robin Williams had. And for a while, there was a lot written about that. And unfortunately, Bruce Willis is suffering from a language aspect of frontotemporal dementia. So again, these are two very prominent people. Not all dementia is Alzheimer's dementia. What is not dementia is an important thing, because I'd say more people used to walk into my office. They forgot their keys. They forgot somebody's name. They couldn't remember Julia Roberts was in Pretty Woman. And they said, oh my God, I'm losing my memory. I'm getting demented. Normal aging is not dementia. And the aging brain does slow down, but it's not dementia. We'll talk about that. There's another term which is kind of in the netherworld between normal and dementia, and that's called mild cognitive impairment, which we'll talk about as well. So this is what normal aging is. It's a slowing down of retrieval of information very often. Just like we can't run as quickly, we can't retrieve information as quickly. But we're not demented. We can function fine in the real world. We can do everything we always did. We can do our job. We can pay our bills. We may retrieve things slower, but actually if you test an older person who's normal, if you give them a very timed test, they won't do as well as they did when they were 20. But if you say there's no time to this, take your time, do the test, they do basically as well. It's just the speed. And they do have sometimes trouble learning new nouns and words. And the only reason I mention that is it's very tough to learn Italian when you retire at 80, for instance. It's not going to happen. It's built-in frustration. The other thing that you can't do as well, because it requires speed, and something that we all do in our daily lives, is multitask. Multitasking, I relied on it forever. 6 things are going on at once, and I enjoyed juggling the balls. But as you get older, it's not that you can't do it. You can't do it as quickly, so you'd stop dropping the balls, or you might forget to do something, and you go, oh my goodness, I'm getting demented. No, that's normal aging. Very important. The other thing that looks, and it might become dementia, is mild cognitive impairment. And that's really a term used for people who have intellectual decline below what is expected for their age, but they're still able to function. I like to think of basically dementia as a true disability. It's a disabling disease. I think of mild cognitive impairment as making you inefficient. You don't do things as well or as quickly, but you can still get the job done, you can still function. But you test below what you should test for your age and perhaps for your education. It can be tricky sometimes. A nuclear physicist might lose significant function and test still better than a janitor who's lost less function because he started at a lower intellectual level. And sometimes you need really special testing to define that. The important thing about mild cognitive impairment is 10% of people each year go on to dementia, but not all of them ever do. So it's not 100%. Some mild cognitive impairment just stagnates and stays that way. So it's definitely not a dementia sentence, but it can progress. The other things that can look like dementia, this is more for testing and more relevant when you're in a doctor's office. When we do tests, which I'll talk about briefly, you're going to see certain things that we do just to test your cognition. Naming things, spell backwards the word world, remember things. If you have some of these, if you're deaf, you're not going to do his test as well, and the doctor has to pick up on that. Mr. Magoo takes a test. He's not going to do as well on a cognitive function. Interestingly, deafness and hearing loss is actually linked to dementia as well, independently. So it's both something that can mimic dementia, but it's also linked to progression or risk of dementia. And hearing aids have actually, I mentioned that to a lot of the men, I wear hearing aids. For people who don't but have hearing loss, it actually may decrease the progression of dementia. Language, if you have a small stroke and you lose language, you may not be able to perceive what the person's saying, and yet cognitively, you're really quite intact. So sometimes that can confuse a doctor, and you could look demented. Drugs, any drug obviously could impair you. That's not truly demented, but you always have to be aware of the person who says, every night I take Zolpidem to get to sleep, and I'm taking Ambien, and it's hanging on too long. They can actually look cognitively impaired. Depression is both a mimic of dementia and can be associated with dementia. Patients who are depressed, you'll ask them questions and you'll do a test on dementia. They're not even trying. They're not interested. They're too depressed, and they will test poorly, but frequently they will not be. However, and that's called pseudo-dementia. However, some patients who are demented, one of the behavioral manifestations of their dementia is depression, so it can go both ways. And the last thing, I went from bottom up, the last thing is delirium. And delirium is simply something that happens. It's usually a chemical abnormality that makes you have impaired thinking, but it's temporary, it's transient. Person comes in with diabetes and crazy high sugars, or very low sugars, or very infected, or they've just taken a drug. They can look like they're impaired, because they are, but that will pass if it's treated properly. That's not a progressive, persistent decline like dementia. These are some of the risk factors for dementia. I mention them because some of them you should think about in terms of living your life. A poor diet. It's been shown that the Mediterranean diet actually can slow down dementia. That's worth knowing. It's a very good diet. It's what we should all eat anyway, but it actually seems to have value. A sedentary lifestyle is bad, and exercise is good to help prevent or slow down the progression of dementia. Cardiac risks, things like high blood pressure, diabetes, high cholesterol. Again, because a very common cause of dementia is vascular dementia, those tiny little changes in blood vessels. If you can slow down that risk, you can slow down dementia. Hearing loss, I think I just mentioned, hearing aids. You've heard of the chronic traumatic encephalopathy of football players. Incredibly common. A frightening thing I read actually for this was they did a study of people who had died for other reasons who were football players and had concussions at age 30, and 30% had early changes of dementia in their brain. Atrial fibrillation. These medications can cause sedatives and anticholinergics like high doses of Benadryl or certain drugs that people will take for bladder control. They can cause confusion and delirium temporarily. If you take Valium, you can look demented, but it's really a delirium, a temporary thing. But if you take that over years, it's actually been shown that it can cause actual chronic changes that are irreversible. Again, so these are all things that we are capable of modifying and are worth knowing for that reason. When we think of dementia, and again, I'm going to leave this large category to Dr. Fitzpatrick, we think about it as primary dementias and secondary dementias. Primary dementias are those cellular abnormalities on the cellular level that seems to be intrinsic to the cell. Something's going wrong with the machinery of the cell. Certain proteins are usually building up. In the case of Alzheimer's, it's a protein you may have heard of called amyloid. In the case of some of the others, it's a TDP43, not 42, but 43. But these are all primary neurodegenerative diseases. They're progressive, and we don't really have great cures for them, and we don't often even know why they're occurring. But there are many of them, and again, many of them are linked to Huntington's chorea, was Woody Guthrie. I mentioned, Robin Williams. They've really gotten a lot of press, and they're really important dementias to think about. They behave differently. They present slightly differently. Some of them don't even present dramatically as memory loss in the beginning. They might be behavioral, or they might have some movement disorders. But again, they're primary. We don't have a secondary cause. Secondary dementias are other diseases that we can actually often treat that impair brain function and can look and really are dementia if untreated. And we break those down into a very large categories. You don't have to remember this slide, but just to know certain chemical, certain diseases of the meninges, which is the lining of the brain, and the brain itself. If you have a stroke or a hematoma, which is a blood clot, or an infection like encephalitis, it can affect your brain function and you can become demented. Syphilis can cause dementia. We know that after, unfortunately, some very large studies, but it often can be treated. B12 deficiency, thyroid disease, these are treatable causes of dementia. The problem is they only make up 6%. That's the distressing thing. This is something we use for medical students. It's kind of a mnemonic, if you like mnemonics. It's called dementia. And actually, it can be pretty helpful. It picks up most of the big causes of memory loss. Why do we even think about that 6%? Well, we usually think about that. Most people coming in my office who are 80 years old and have memory loss are going to have a neurodegenerative disease. Occasionally, they can have a clot or a tumor or something else, but most of them are. But if they're young, if they're 50 years old, and there are dementing diseases that are neurodegenerative in 50-year-olds, but if they're young, or instead of being a slow, gradual, progressive decline in intellectual function, it's very rapid. Or if they have some movement disorders, or their tests are abnormal, or they have cancer or something else that would make me think maybe something's in the brain, then we go full-out testing. We'll do MRIs, blood tests. We might even do a spinal tap. Majority of people, we do some testing, but unfortunately, 6% is not a really high yield. So how do we assess these people? Well, the way we assess them is first by the history and the physical. And one of the things I've just found is if a person walks into my office and says, I think I'm demented, they may be right, but there's a very good chance they're anxious, they're depressed, they're not accepting the changes of age in the way, but they may be. If a family member walks in, if the spouse walks in and says, my spouse is, I think they're becoming demented, I find they're usually correct, unfortunately. An objective observer is very, very helpful. And then you go through what their reasons are, what's changed. You know, are they having behavioral changes? Are they forgetting things? A very common thing is they were driving and they have this visual spatial problem and they get lost in an area that's their neighborhood. or they go down one-way streets that they've driven for 20 years. That's an early sign of dementia and very helpful. The cognitive testing is the thing that we start with, because you can't just gestalt it necessarily unless it's severe. But there are tests designed to compare you to age-appropriate and possibly educationally appropriate people to see if you've really declined that much. And I'll go through those quickly. The rest I'm going to leave to Dr. Fitzpatrick, the labs, the brain imaging, the spinal taps. There are now markers in spinal fluid and in blood that we can help use to make diagnoses of dementia, and some fascinating nuclear scans that can be used as well. This is a typical test. This is called a mini-cog, and basically it's a test that you ask word recall, clock drawing, and you then ask them to recall the word. It looks very simple, but this is what people with dementia might do if you ask them to draw 10 after 11. There's something seriously wrong here. It's really not uncommon to get these radically weird things. This is another test commonly called the mini mental status that tests memory, orientation, spelling, arithmetic, basic concepts. This is a test called the Montreal test, the MoCA test. I only mention this because this is a very commonly used test. It was the test that President Trump said he did so well on. He wasn't demented. That's really what, and this is a slums exam, another common exam, and I just love the name. One thing I do want to emphasize, dementia is, I like treating dementia. It sounds weird because you can't really do great things for it, but an internist can do a lot in terms of keeping the patient healthy and keeping the patient functional and keeping the patient in the right place that they need to be. And I found that very gratifying. It's really a privilege to take care of people because it's a long process. Dementia, they're not in pain. It's usually the caretaker that's in pain, watching the dementia, but they're not in pain, and they're going to be around for 8 to 10 years, and you have to take a journey with them all along the way, and it can be very gratifying and very helpful. One of the things, this is my list of things I like to do. I actually kept a card. Very briefly, first thing I do is I use these terms to see where the person belongs. ADLs are activities of daily living, very basic activities, eating, toileting, hygiene. Instrumental ADLs are things that are a little more complicated: driving, cooking, transportation, paying bills. If a person can't do this, they need some kind of assisted living or assistance. But if they can't do this, they really need a caretaker. And you can look at this very quickly and define what they can do. Another thing that becomes very problematic sometimes is behavior, agitation, anxiety, and there's a lot one can do. We can talk about this later perhaps, but there are things you can do to calm them non-pharmacologically. You don't have to treat them with medications necessarily, and obviously each one of these also has a medication that you can use. So you can go either way. But again, it's important to treat the agitation and the behavior, because that's often what drives a family member to say, I can't take care of them anymore. They're out of the house, they have to go to a nursing facility. The most important thing for me as the internist is, and I sometimes have to play the heavy, there are social functions that are dangerous. Person's not going to die because they're demented, but they will die if they continue driving. And so you may have to be the one, the family says, I can't take their license away, so I have to take their license away. Finances, they can keep paying bills forever, or not pay their bills and have their lights turned off. Somebody's got to take over their finances. In terms of their medications, these people are often on multiple medicines. They can't take 3 of their anticoagulants or 4 of their heart medicines and keep forgetting. Somebody's got to give that to them. This is really what gets them in the most trouble. And something I really wasn't cognizant of until, unfortunately, a situation arose on a patient. I didn't realize how many people in Connecticut have guns. And if you're a demented old man with guns and your grandchild is living in the house or visiting, it's a very dangerous combination. So guns should be removed from the house as well. But if you remember nothing from this, just remember, if you have somebody in your family who's suffering from dementia, these 4 things have to be attended to. The other thing, and everybody who has early dementia, and the family has to be accurate about this, is people need advance directives. You need to have a living will. You have to know what you want in your life, how you want to be treated, if you're going to know that you have a progressive disease. You really don't want necessarily heroics, or maybe you do, but you should say it when you can clearly manifest what you want and explain what you want. And the rest of these are interesting because they might slow down dementia. So cognitive retraining is basically teaching people about lists, perhaps doing games. There are a variety of different things on the internet that you can, playing Wordle even perhaps. Those kind of things, keeping the brain as a muscle, using it will help the muscle. Vascular risk factors I mentioned already, things like blood pressure, cholesterol should be addressed. Why? Because you want to save the vascular disease. You don't want it to progress. You don't want little mini strokes. Lifestyle, very important. The Mediterranean diet, exercise, I already mentioned using brain in the muscle, and really limit alcohol and sedatives. Sedatives can have acute effects, they can have chronic effects. People with alcohol can have acute effects, and you can have a drunk brain, which is a chronic effect. So these are things you can do to slow down disease if dementia has already started. Advanced directives, and I'm going to just end with the most important, I think, is caregiver support. It is, you know, there's multiple books, The 26-Hour Day, lots of things on dementia that's been written. It is an incredibly demanding thing because not only does it require your caregiving if you're the caregiver, but it's also depressing. It's hard to watch somebody you love decline. And these people need respite, they need assistance, they need support groups. These are some of the groups that really do provide that. Obviously, there are daycare centers, elder care centers where patients can go during the day. And at a certain point, if they can't do those ADLs, that hygiene, that toileting, they may require either a full-time caregiver or they may require a different place to live. But it's very important because these are the people who often suffer more than the patient. At that point, we're going to get into the more intense and deeper aspects of Alzheimer's treatment and dementia with Dr. Fitzpatrick.
Well, thank you, Dr. Thank you, Dr. Altbaum, for the introduction. And it's always a pleasure to learn things, even when you think that you know it all. Okay, let me see. How do I switch over from? Where's mine? Let's see. I am gonna want. I need slideshow view. There we go. All right. Okay, and it started all the way at the end. Hold on. That's not good. Hang on. See if I can. There we go. Okay. All right. So I was tasked with chatting a little bit about some of the pathologic causes of dementia, as well as some of the newer therapies that we have. But I'll talk a little bit about the older therapies because sometimes that can be enlightening. I don't have any financial disclosures. So, as Dr. Altbaum had pointed out earlier, we think about many different kinds of dementia. Dementia really is just like the umbrella term that encapsulates a variety, a syndrome, the inability to perform various cognitive tasks, as well as a decline in functional independence. I think about dementia as sort of belonging to different categories based on a couple of things. Number one, the symptoms, that is sort of what functional parts of the brain are impaired. And so that can be thought of as whether or not certain lobes are involved, like the frontal lobe versus the temporal lobe. It sort of roughly corresponds to various cognitive domains, as we saw in the previous slide, that map out to large or whole brain functional networks that span multiple lobes. I also like to think about the dementias as sort of sometimes having a Parkinsonian versus a non-Parkinsonian flavor. We'll get into that a little bit more later, but that has a lot to do about whether or not deep structures are involved or not. But also, dementia is something that is going to manifest a little bit differently at different ages. So chronology definitely matters. How old are the patients when they initially start to have symptoms, and what is the overall time course of that? So there are certain organic dementias that are earlier in onset, that is to say that they afflict individuals under the age of 65, as opposed to those that are more common in later years that would be sort of greater than 70, but usually we use 65 as the cutoff. And then over the course of a patient with dementia, most of them are going to have gradual changes. So it can be very difficult to sort of see a change on a day-to-day basis. However, with one specific variety of dementia, there's what we call a stepwise progression, and that goes with vascular dementia. So Dr. Altbaum showed you the slide with all of the cognitive or the neurocognitive domains, but this is how I look at them as sort of having a specific lobe. Yeah, sorry about that. Yeah, so so we start with sort of the visual processing, the visual processing network. That is to say, can you perceive what you're seeing? Can you construct things from your visual input? And are you able to connect what you're seeing and what you're hearing with certain motor outputs? So, say, for instance, reaching for a glass. Within the prefrontal cortex, we have, again, more in the realm of planning and decision making, but also aspects of working memory, inhibiting certain responses. So sometimes this actually manifests very strongly in sort of a social context. Can you not make remarks that are going to offend people? And can you be flexible in your thinking? Between the frontal and parietal lobes, there's a rather large attentional network, which is important for maintaining attention to certain things, dividing your attention, being selective with it, and also is an important aspect of your overall processing speed, a thing that tends to get a little bit decreased as you get older. Language is sort of the bane of many, a medical student and a young neuroscientist because it's so complicated and it's involved in so many different lobes, but in general, sort of connections between the frontal and temporal lobes. It's arguably the most common symptom that I see in my clinic amongst younger patients who come in saying, I think I have developing dementia, I'm not able to remember certain words. I'm having trouble finding words, but it's so much more complicated than just individual words. There's grammar and sentence arrangement and vocabulary that can be impacted by true organic dementias. The memory network is arguably the biggest issue when it comes to dementia, and that can be measured in a lot of different ways. There are sort of what we think about as more verbal or semantic memories, where you're trying to remember something that was told to you from a language standpoint, but there's also visual and spatial memory as well, the thing that tends to get impaired when a person becomes lost easily or has trouble finding things, say like where you put your car keys or your cell phone. And we'll talk a little bit about sort of the long-term memory and not so much about implicit learning. And then finally, between the prefrontal and temporal lobes, we have things like recognition of emotions and ability to form insight into things, sort of linking into the social cognition aspect. So that's how I usually like to think about the cognitive domains. So when we have a new patient, as Dr. Altbaum had pointed out, usually we do a few things. Number one, we do a neurologic exam. We try to look for some supplementary clinical findings that might help us determine whether or not a person is having signs of neurodegeneration. One thing that I'll often end up doing is tapping on a person's forehead. It seems a little strange, like I'm saying, is anybody in there? But actually I'm looking to see whether or not they have the ability to suppress a certain primitive reflex. If you have degeneration in your frontal lobe, it's very difficult to suppress that reflex, and you can actually do this to babies, and they will blink every time you tap in the middle of their foreheads. You can also stroke their hands, and you'll have a little bit of quivering in their chin. That's called a palmamental sign. But also we're looking for other potential explanations for why a person might have difficulty with their memory or with other aspects of their ability to think. We do the cognitive screening, as Dr. Altbaum ran through before. My favorites are the Montreal Cognitive Assessment and the Mini Mental Status Exam. Now, we may also refer a person out to neuropsychologists to do formal testing, which is really helpful for those subtle cognitive deficits that are not sort of very frank dementias, but might fall within the mild cognitive impairment range. As far as neuroimaging, I apologize, I didn't get any great pictures, but in terms of imaging studies, most often we aim for an MRI of the brain, primarily to search for evidence of small blood vessel disease, as we'll point out in the future. But also you can pursue positron emission tomography, which is a specialized form of scanning, nuclear medicine scan, which can help to distinguish certain kinds of dementia, as well as to establish certain pathologies that might help lead to therapeutic interventions. Spinal fluid testing, fairly self-explanatory. You take a needle and acquire a sample of fluid from the patient's lower back, and then run tests on it. And most often what we're looking for is evidence of either tau protein or amyloid, which we'll talk about in a second. We also have a tendency to order other types of studies like electroencephalograms, which evaluate for epilepsy and seizures, certain blood tests like thyroid studies and vitamin B12 levels to look for reversible causes, and sleep studies occasionally. I didn't actually hear a whole lot about I would argue that undiagnosed sleep disorders like obstructive sleep apnea are a major cause of cognitive decline in younger individuals, or at least a sort of a potentially reversible cause of cognitive issues in patients who are under the age of 65. Because if you don't sleep well, you don't replenish your cognitive reserves, you don't clear out metabolic waste, and you'll have trouble sort of maintaining an adequate working memory and attention. Okay, so. Now, I know we looked at this already, but it actually forms a decent synopsis for what we're going to talk about first. So I'd like to bring your attention to the roughly 18% in the upper right-hand quarter, vascular dementia, as well as the sort of overlay of Alzheimer's and vascular dementia. It's important to remember that sometimes patients can have more than one reason to have dementia, and that sometimes impacts their care. So vascular dementia is really what we used to call multi-infarct dementia, which sort of indicated that a person had suffered multiple small strokes that were impacting their ability to think. And as I indicated before, it has a distinct chronological pattern where a person will be normal for a while and then suffer an abrupt worsening, followed by a period of relative stability, followed by another abrupt worsening, and each of those abrupt changes in their ability to think is thought to be related to some acute event like a silent stroke. So they don't have to be particularly large or debilitating, as we'll see in a second. But in general, disease of the arteries in the brain results in impaired blood flow to certain sections of the brain, which impairs their function, which means that vascular dementia is really hard to identify from a specific set of symptoms. It depends on what parts of the brain are impacted. It can mimic other dementias, so if you have a lot of impairment of blood flow to the frontal and temporal lobes, you could look like you have frontotemporal dementia when in fact you just have had a lot of vascular disease impairing the associated lobes. And it can be superimposed on other dementias, so as you've seen, you can have Alzheimer's disease and cerebrovascular disease leading to sort of a mixed dementia pattern, okay? So MRI is arguably the most sensitive tool, as there's a case of an example of a silent stroke here within the some of the periventricular white matter on the left side of a brain. But more importantly, all of these bright spots around are indicative of areas where blood flow may be limited but not completely blocked off, okay? These are areas where the brain is starting to swell a little bit on the cellular level, and because it is a little more dense, it causes changes in the behaviors of water molecules, and that causes a change in the magnetic field, which is detected by the MRI. Okay. Now, prognostically, I don't have to go into too great of a detail because I think there is another very good lecture about stroke before, but the management of vascular dementia depends very much on managing risk factors for stroke, which, you know, the most important one all the way at the bottom, I just ordered them alphabetically, is smoking. But managing things like cholesterol, diabetes, and high blood pressure, as well as sleep apnea, which is an independent risk factor for the development of small strokes, and atrial fibrillation and other causes of increased blood clotting are all very important things to consider. Now, getting into the bulk of things, Alzheimer's disease, obviously, the majority of organic dementias, but realistically, actually more like 70% when you include the numbers that have overlaps between Alzheimer's and vascular or Alzheimer's and dementia with Lewy bodies. What we see with Alzheimer's disease, I'm going to get into the pathology behind it, but predominantly there's an impairment of the temporal and parietal lobes within Alzheimer's disease. So learning and memory is a predominant domain that's affected, and oftentimes this has a preference for short-term memory. So you may not remember what you had for breakfast this morning, but you can still remember, you know, your friends from school when you were in college. And so long-term autobiographical memories are relatively well preserved. You think about it, you know, you're holding on to memories over a long period of time, but when you're forming early memories, you have more storage space, so you make more copies of them, and they are a little bit more difficult to obliterate. When you get to relatively new memories, you may only make a few copies or like a single copy of those, and it's relatively easy to overwrite or otherwise obliterate that memory. Okay. Now, later stages of Alzheimer's disease can cause impairments in complex attention, as well as language and the perceptual motor domains. In the final stages, there's often an impairment in motivation, which leads to sort of a state which we call the neurovegetative state, where there's not a lot of spontaneous activity going on. They can still sort of react to things, but not a whole lot. So to sort of illustrate the areas that are predominantly affected, looking at areas where the temporal lobes play a larger role. Actually, probably should have circled this as well, because often there's poor insight in advanced Alzheimer's disease into their condition. So what we call anosognosia, or an inability to recognize one's own impairments. The frontal parietal attention network and the parietal occipital lobe networks can also become impaired. There's one very specific form of Alzheimer's disease called posterior cortical atrophy, which has a predilection for the occipital lobes, and that causes all kinds of impairments in visual processing, as well as sometimes hallucinations. Okay, so when we talk about a person having Alzheimer's, previously, well, even now, we often, what we mean is that they are suspected or probably have Alzheimer's disease. This is really intended to be a tissue diagnosis that's made either through autopsy or biopsy. Now, there are, as I said, spinal fluid tests as well as PET scans, which can give us indicators of the presence of underlying proteins like amyloid and tau, which we believe to have a causative relation with the development of the disease. But historically, getting tests like this did not really change management. We didn't have targeted therapies for it, so we didn't actually order those. Okay. Now, the mechanisms underlying Alzheimer's are very complicated. So there are misfolded proteins, sort of on a more global scale. There are deficiencies in certain neurotransmitters as well as genetic abnormalities, and then several environmental and lifestyle risk factors that contribute to oxidative stress, which is basically a condition of producing oxygen-free radicals that can damage DNA. Okay. So we're going to talk about some of the hypotheses as they relate to therapeutics, the more dated cholinergic hypothesis as well as the more modern tau amyloid hypothesis. So a long time ago, it was observed that in patients who have Alzheimer's disease, they have a depletion of a certain neurotransmitter called acetylcholine in their brains. And acetylcholine is extremely important for allowing certain brain cells to communicate with one another. There are, again, this is sort of going back to integrated neurosciences, second year of medical school, these large-scale networks within the brain where a specific neurotransmitter is produced within a small nucleus, usually down in the deep sections of the brain, like the midbrain or the pons, or in some of the basal ganglia that enhance brain activity at higher levels. So you can kind of think of it as the, oh yeah. Sure, of course. Yeah, so here we go. So here within, say, the cholinergic, system, you have the production of a large amount of acetylcholine within the nucleus basalis of Meinert, which then, actually, that's over here, which is then distributed to various brain cells throughout the outer portion of the brain called the neocortex. And essentially, it's sort of giving the green light to activate sort of large areas of the brain all at once. There are at least 4 different ones as we've identified here. There's cholinergic, there's the noradrenergic, which is another way of saying a type of epinephrine. There's the serotonergic, which operates primarily on serotonin, and the dopaminergic, which is very important in the development of Parkinson's disease and runs on dopamine. Okay. So early therapies were aimed primarily at trying to replace the acetylcholine that was deficient within Alzheimer's brains, which led us to the acetylcholinesterase inhibitors. Acetylcholinesterase is an enzyme that breaks down acetylcholine, okay? And if you're able to inhibit that enzyme, then you have more acetylcholine available. So these are medications like donepezil or Aricept, which is sort of the most commonly prescribed medication for Alzheimer's, as well as several other types of dementias, ribostigmine or Exelon, and galantamine or Razidine. Okay. So essentially you're trying to support the cortical activity that's normally stimulated by acetylcholine, and through that you maintain neuron density, you maintain connections between deeper structures in the brain and the cortex, which slows down the degeneration of those neurons. A brain cell that is not receiving any stimulation or any input is going to flag itself for destruction, okay? So you slow the progression of dementia. The side effects of these are also worth noting, although there are a few here. They generally are really well-tolerated medications. They can cause some temporary diarrhea and GI discomfort. They can cause dizziness and balance disturbances, which is why we usually advise patients to take them at night when you're going to be lying down. They can lower your blood pressure and heart rate, which is sometimes a limiting factor in starting these medications in older patients who may have conduction problems in their hearts. It also causes vivid dreams, which I've had many patients tell me all about their wonderful experiences in dreamland as a result of being on Aricept for the first time. The other medication that often will get started is called memantine, which goes by the brand name of Namenda, which is an antagonist of the N-methyl-deaspartate, or NMDA subtype glutamate receptors. Now, glutamate is really important. It's actually arguably one of the most prevalent signaling molecules within the brain, and it's essential for normal function. However, as with many things, too much of a good thing can be bad, and excessive, persistent activation of glutamate receptors leads to a lethal influx of calcium ions. So memantine essentially binds to these receptors that have already been activated and prevents the calcium from entering further. It does not, however, bind to inactivated receptors, so you can still have normal physiologic function without running an excessive risk of glutamate toxicity. And that helps to keep more brain cells alive, thus slowing the progression of dementias. Now, I didn't put it on here. Memantine can be a little bit challenging to use, especially given that abrupt cessation can cause a lot of confusion. I usually wait until a person has already demonstrated some progression on Aricept alone before starting memantine. Okay. Now, moving on from the cholinergic hypothesis into a more modern hypothesis of how Alzheimer's develops, we have in general this notion that a lot of the primary dementias are related to accumulations of abnormally folded proteins. This really begins with genetic mutations, which cause adjustments in or abnormalities in enzyme function, which are essential for processing the proteins before they become functionally active. Okay. Oftentimes, abnormalities in processing causes a conformational change in the protein, leading it to be less soluble and more likely to aggregate, thus forming these plaques and tangles that we describe as collecting within neurons. Essentially, it's just undissolvable waste that you can't remove unless you have something very specific, which we're going to get to in a second. Okay. So we'll start with that. Within these, there are three genes out of many that we like to talk about: the amyloid precursor protein and presenilin, which both play roles in cell surface signaling, which regulate the development of synapses and the proliferation of connections between neurons. The presenilin forms an enzyme that converts amyloid precursor protein into amyloid beta, which unfortunately, if it's allowed to be a little bit too long, that is amyloid beta 42 as opposed to 40, it forms these insoluble aggregates that precedes the development of tau aggregates, sometimes by several years. Okay. Unfortunately, that leads to abnormalities in tau protein aggregation. Tau protein is this protein that's normal in neurons and is associated with microtubules, which gives cells their structure. And if you put too many phosphate molecules on it, they become insoluble and form tangles. Okay. Now, tau aggregates are present in many different kinds of primary dementias, so it's not unique to Alzheimer's disease. It's also present in frontotemporal dementia, Pick's disease, even some what we would consider to be secondary dementias like chronic traumatic encephalopathy and Huntington's disease. Okay. But this is a slide essentially to kind of illustrate the changes in the patterns. So within these, initial changes, either oxidative stressors, you end up with some destabilization of the microtubules and the phosphorylated tau. The tau begins to form these oligomers which form tangles, and they can actually, unfortunately, spread from one neuron to the next through transmission pathways. They cause a bunch of or inflammatory responses, as well as dysfunction with the mitochondria and impairment of the synapses, which eventually leads the neurons to degrade. Okay. Early and late onset, very common question. Patients come in, they say, well, I have a family history, what's my overall risk? Most Alzheimer's disease is not early onset, only about 5 to 10% of cases, and greater than 90% of these are inherited in some form. Okay, often they're associated with mutations in those genes that I just talked about, the presenilin and the amyloid precursor protein genes. Most of the time, 50s to 60s. If you're coming in your 30s or 40s concerned about it, you're not there yet, unless you have Down syndrome. It's, amyloid precursor protein is coded on chromosome 21, hence why it is, why it's a problem. Now, late onset Alzheimer's disease is defined as starting after the age of 65, although as Dr. Altbaum pointed out, most of the cases are going to be in their 80s or 90s. It accounts for 90 to 95% of all cases, and still 70% of them are inherited, but often we're talking about recessive mutations of some of the genes that I talked about. So if you don't have a strong family history of Alzheimer's disease, a vast majority of the time, you're looking at a late onset, not an early onset. It's extremely uncommon to have early onset with no family history whatsoever. The most important gene mutation that's predictive of the development of late onset Alzheimer's disease is apolipoprotein E, okay, which specifically apolipoprotein E4, which has this poor activity in the removal of amyloid beta plaques. If you have one copy of it, it increases your Alzheimer's disease risk by 3 times. If you have 2 copies, over 15 times. Okay. Now, that leads us into the immunotherapies, and I realize I'm running a little bit low on time here. Essentially, we started out with attempting to vaccinate against amyloid beta, but that didn't really work very well, and unfortunately, some of the patients developed fatal cerebral edema, so that was not continued. However, we started to develop. Cerebral edema is essentially swelling of the brain, which is not a good thing. Your skull is a compacted space. If you try to increase the amount of brain in there, you leave less room for things like blood, and that causes problems. As well as sometimes brain leaking out through holes where it's not supposed to come out. That usually results in lack of breathing and passing away. Now, there are several antibody infusions that were later synthesized. So basically, rather than trying to induce a natural antibody response in the body, we just create our own in a lab and infuse it. Of these, probably the most important ones were lecanemab, which recently got FDA approval this past July through the traditional pathway. Aducanumab, which got an accelerated approval back in June 2021, but we're not actually sure that it works as well as lecanemab, and donanemab, which is not yet been approved, but is showing promise in phase 3 clinical trials, as well as there are several other failed trials as listed there. Now, the pretreatment workup is important. You have to get an MRI of the brain. You have to get blood tests, yes. The MRI is important for assessing bleeding risk, and you have to get an amyloid PET or spinal fluid tests to confirm the presence of amyloid. If you don't have these, you're not going to benefit from the amyloid beta immunotherapies. It's also critically important to get genetic testing because that can greatly increase your risk of having swelling, that is edema in the brain, as well as bleeding, okay? And at present, CMS and insurance carriers have not really clarified how they're going to cover all of these pretreatment studies. So oftentimes it comes through out-of-pocket costs, or it may be covered if you join a clinical trial. Okay, so at this point, getting treatments like these is either going to run you $35,000 out of pocket, or you're going to have to submit to some tests. You have to get MRIs at least 3 times during the infusions at 10, 14, and 24 weeks. You're looking for bleeding and swelling, which is present in up to 11% of patients, and can cause headaches, confusion, and depressed mental status, meaning you get sleepy. And in 0.5%, you can have symptomatic bleeding. If you have ApoE4, 1 or 2 copies. You have to get additional MRIs at 20 weeks and 1 year. So what does this mean? Well, we really can't approve these medications for people who have chronic needs for blood thinners, say someone who has AFib or who needs to, or has blood clotting disorder. If you're unable to get serial MRIs of the brain, if you have a pacemaker or defibrillator or a spinal cord stimulator, you really can't do that, or if you have severe claustrophobia. And if you already have moderate or severe dementia, it's probably not worth it. And it goes back to the medications essentially slowing down the progression of the dementia rather than actually reversing it. So they've found that a lot of, there's good responses and slowed progression when you're able to completely eliminate amyloid plaques from the brain, but you still have the tau fibrillary tangles that don't really change much, and those are really causing a lot of the ongoing level of impairment. So there's no progression, but there's no improvement. So if you're already requiring basic ADL help, if your cognitive assessments are below 10 out of 30, or you have a high likelihood of advanced neurofibrillary tangle presence. I'll go quickly on frontotemporal dementia. Essentially, this is an early onset dementia, the most common cause under the age of 60, and it causes deterioration in the frontal and anterior temporal lobes. This is the one where there's pronounced changes in personality as well as language. One of the major forms is primary progressive aphasia, which is what Bruce Willis has. It also has a high association with ALS, or Lou Gehrig's disease, and often forms a complex. I had a very sad case in my own clinic of a gentleman who probably was starting to develop some primary progressive aphasia and came back several months later with more pronounced ALS features. Tau and the TDP43 proteins are the main proteins that are implicated here. There are a couple of other ones, but we don't really have time. So temporal lobe network, prefrontal cortex, prefrontal and temporal lobe impairments, which sort of forms the, I guess, the constellation of symptoms seen here. Diagnostically, you can usually separate it from early onset Alzheimer's disease by history and symptomatic reports, but FDG PET scans can also identify areas where metabolism is going to be different in early onset Alzheimer's disease versus frontotemporal dementia. It doesn't necessarily lead to a change in our management, however. And then the treatment is largely supportive, so antidepressants and sleep aids, among other things. And then we have Lewy body dementia, which belongs to a larger group of neurodegenerative disorders related to the accumulation of a protein called alpha-synuclein, which is common to Parkinson's disease, among other things. It is distinguishable clinically by the development of Parkinsonian symptoms, as well as these well-formed, non-threatening visual hallucinations, usually describing seeing, say, small animals. Where I trained up in Dartmouth, we all had to be very careful. If they'd said that they saw rats or mice, they were probably hallucinating. If they saw deer and turkeys, they were looking out the window. Okay. Because we had those. They also have abnormal movements in REM sleep, which manifests as acting out of one's dreams. The diagnosis may include a dopamine scan and a sleep study, but is largely clinical. I'd mentioned sort of Parkinsonism, which is this clinical combination of a resting tremor and rigidity with slowness of movements and gait instability that's seen in a lot of different conditions that also can manifest with dementias. Now, Parkinson's disease itself carries an increasing risk of dementia the longer you have the disease. Depending on where you're looking, that can be anywhere from 30 to 80% after 10 years with Parkinson's. I don't think 80% is matching my clinical experience, but maybe closer to the lower end. But there are other related conditions like corticobasal ganglionic degeneration and progressive supranuclear palsy, which are actually like Parkinson's disease variants that affect younger individuals in the sort of 45 to 65 range, or 45 to 75 range, with a peak in the early 60s. And hallucinations are a feature of dementia with Lewy bodies, and as well as other types of dementias. normally we treat this with antipsychotic medications, but because Parkinson's is a condition of depleted dopamine, that can be problematic because adding an antipsychotic will cause problems, will cause worsening of the Parkinsonian symptoms. There is a treatment for that called pimavanserin or Nuplazid, which is this novel serotonin agonist, which is safe to use in Parkinson's dementia. Okay, I know we've breezed through that, so we'll open up the floor to questions.
If you have any questions, please come to this microphone right over here on the side of the forum so that everyone can hear you.
I just wanted to make one comment. That was quite a review. I don't think we'll test you on all that. But one of the things that Mike really didn't emphasize is, unfortunately, all these treatments are really mediocre to bad. The anticholinesterase inhibitors, basically, if they do work, basically extend or slow down the dementia about 4 to 5 months. It's like one season in a year. It's not a lot. Memantine, the same thing. Not very effective. These new drugs, forgetting the fact that you have to take them indefinitely, and they just slow things down. They cost $25,000 a year, at least at this point. One of them was very controversial. People on the FDA actually quit because they didn't think it justified FDA approval. And unfortunately, getting rid of that amyloid protein doesn't really get rid of the dementia for the reasons you mentioned. There are other proteins and other things involved. So it's a very tough treatment. And again, a lot of the things that we do for Alzheimer's patients and demented patients have nothing to do with the medications, but really maintaining them and allowing them to enjoy their life.
Oh, look, a deer. Oh, look, a rat. So we'll take your questions now. My thanks to Dr. Fitzpatrick and, of course, Dr. Altbaum. Yes. Please.
Not a medical question, but more a question about your experience and perhaps in the ethics. There was an interesting essay in the New York Times within the last month to talk about advanced directives. And while the person was in full cognitive, fully in control of his cognition, said, I do not want, in the advanced directives, I do not want any exceptional treatment. On the other hand, when he was into his dementia, he was perfectly happy and would not have signed that kind of forget about, and, you know, do not resuscitate. What has your experience been with patients around the issue of advanced directives?
Well, again, one is I'm a big believer in advanced directives. You mentioned two things which are interesting. One is that a lot of patients with dementia, at least for the first 5-6 years, they're not suffering. Again, it may be hard on the caretaker, but they're not in pain, they're not short of breath, they're just not functioning at their best, but they can still get pleasure. There are groups called reminiscent groups that they can go to, where they can actually remember things from many years ago and have a wonderful time. So it's not as depressing as people think. I'm a big believer in advanced directives because at a certain point, this disease and many other diseases rob you of the ability to make the decisions. Advanced directives can be reversed. Often a person who has an advanced directive also has a power of attorney, somebody who's going to make those decisions for him or for her. And that person, if they have misgivings or the person's really enjoying their quality of life, even though they can't make an accurate decision about their advanced directive, it can be changed, it can be modified. But as a general rule, I find advanced directives are a very good way of directing what you want, and they shouldn't be challenged by the family if it's really what the person had wanted. If the person changes their mind, even in an altered state, you have to consider that. You definitely have to consider that.
Marty Yellen.
Thank you. I'm not a neurologist, so forgive me if I don't get it exactly right, but you didn't mention anything about glia cells. And I attended a lecture where they implied that glia cells are like the immune system for the brain, that you don't have a natural immune system because I assume you You don't want inflammation or swelling in the brain. And they showed these fantastic high-resolution images of glia cells over the axons. And some of them only covered part of it, some of it covered the entire axon. And the ones that covered most of it did not get plaque or tangles or tau. But the ones where the glia cells were not big enough to cover it did. The bottom line of this paper was that we should be attacking glia cells, trying to understand why they're being reduced in size that allows Alzheimer's to proceed. That's very curious about that.
Yeah, so perhaps something that I maybe glossed over for lack of time. The accumulations of proteins are not just within the cells; they're also outside of the cells and or outside of the neurons. The glia cells are essentially the support system for the brain. Over 90% of the brain's actual weight is all glia, and you're right. Some of them are involved in sort of essentially as acting like the immune system of the brain, where we don't want to have a lot of the more aggressive forms of cells that we have in other parts of the body. But without sort of dancing around the point, the glia that are involved in sort of protecting the axons of the neurons, they may be degenerating because of the accumulations of these same tau neurofibrillary tangles as a result. So they can also degenerate for other reasons. It's not always clear that the degeneration of the glia necessarily precedes the degeneration of the neurons. Sometimes if you have a degenerated neuron, the glia cell recognizes that it's no longer really performing a given function, and it reassigns itself or degenerates on its own. So it's a bit of a chicken and an egg sorry, I'm having a moment. A bit of a chicken and an egg conundrum or paradox. Okay. Mm-hmm. Welcome.
Further questions?
Yep.
Yes. I have a friend who was a surgeon in UK, and after a little injury, a surgery, he had some temporary confusion. It lasted for some weeks and came back. And he and I have speculated that maybe it was weakening of the blood-brain barrier, allowing some of the normal blood to get into the brain where it's not supposed to be. Any opinion on that?
Well, so the blood-brain barrier, for those who maybe didn't catch that, it's a structure that surrounds all of the normal blood cells within the brain that helps to isolate the brain both chemically and immunologically from the contents of the blood. Now, certain small molecules like water and sugar can pass through, but larger things like certain cells as well as large antibodies cannot. When the blood-brain barrier breaks down, which it does in a lot of different conditions, including multiple sclerosis and infections, you end up with things in the bloodstream entering into the brain where they're not supposed to be. So that's the leading theory behind conditions like multiple sclerosis. You end up with invasions of T cells into the brain that cause inflammatory responses. So if you break down the blood-brain barrier, you can have a few different problems. Number one, you can have cells getting into the brain where they're not supposed to be, causing problems because they don't recognize the brain as being normal tissue. So immune cells can attack it, or you can have larger molecules, say like chemicals that are, maybe the drugs that we take may not normally pass into the brain that are now getting in, causing all kinds of metabolic problems for normal brain function. They can lead to a transient state of confusion, which we call delirium, which we talked about. And once that blood-brain barrier is restored, you no longer have the leakiness of things from coming from the blood entering into the brain tissue. Okay, does that make sense?
Yes, thank you.
Perfect.
Next.
So this is less of a scientific question and more of a follow-up to the, advanced directives caregiver question. That if somebody has advanced directives and does it when they're, say at the very early stages of the disease, when they are fully cognizant, they know what's going on, and then later on, and they get to the point where they no longer even understand that they have this condition or disease anymore, and they start insisting on making decisions because they think they're fine, like it's like that repetitive, I'm fine, I'm fine, I'm fine, I'm fine. What does the caregiver do in that situation when this person maintains that they're okay now?
That's actually more of a legal question, actually, than a medical question, because you have to conserve that patient. That would require going to court and taking over conservatorship, which happens. A family member, happens usually a child has to take over the care of their parent, and the parent is really adamant that they're fine when to anybody they're clearly impaired. And at a certain function, you can do that. You can take over their finances. You can take over their medical care, particularly if they've made you. So, I mean, usually you can do that either by default because you're the next of kin, or because they've made you their power of attorney and their healthcare proxy. So that can be done legally, but it's not really so much a medical question if they're refusing to do it.
Mm-hmm. Yes.
I have a decidedly non-chemical kind of question, but I'm curious about at the beginning of dementia, there's sometimes a lot of anxiety at certain times of the day, and I'd like to know if there is a kind of medical reason for that, or is it just that the person sees that they are losing function? And is there anything that you can do to lessen that or make it better?
Well, I'll take it from a non-pharma. There are medications you can use, but anxiety is a big part, and behavioral changes are a big part of dementia, both because it affects those areas of the brain, and also because if you're misplacing your keys, can't remember things, getting lost, it can be very, very frightening. Not remembering people's names, not remembering people in general. Sometimes patients with Alzheimer's or dementia will get very paranoid. They lose something, and then they can't find it. Well, they didn't lose it, they're fine. Somebody stole it. And they can get increasingly agitated. There are a lot of things you can do to calm people down. You obviously reassure them, keep orienting them, talk to them in a way that is very soothing, and don't really confront necessarily. Confrontation, like how can you not remember that? That's just inflammatory. They respond to things like touch and massage. They respond to music. A thing when a person gets very agitated, it's sometimes helpful just to redirect them. They in 5 minutes, they won't remember what they were really agitated about. So you say, oh, Dad, let's walk over and take a look at this. Look at your garden, it's beautiful. And you just shifted the conversation, and they calm down. And if they're truly agitated, and it's inconsistent with their usual ability, like for a given day, there may be something else going on, a medication, they may have some pain, a common thing, older patients, they have urinary problems. A man may have a prostate, urinary retention, or they may be rectally impacted from stool. Sounds simple, sounds almost silly. It's common, and they can't express it. They just know they're having discomfort, and that creates agitation. And then if you can't express it, you get more agitated because no one understands what you're saying. So the first thing is to make sure that there's nothing else going on, and then lots of different modalities of trying to calm them down. And worst comes to worst, medication.
Thank you, very helpful.
And I often find, sorry to piggyback off of that, I often find that if there are sort of problems during a certain portion of the day, the demented brain really craves a lot of regularity. You can become extremely confused by having a normal schedule disrupted. So oftentimes, trying to institute, a very regular, rigid pattern of things, especially towards the end of the day, which I think was what was being hinted at through sundowning is actually extremely helpful. Also, if you do end up going the pharmacologic route or the medication route, rather than any specific medication, oftentimes it's a timing issue of trying to make sure that they are able to get medications that are going to keep them calm earlier in the evening before they are so confused that they're able to sort of refuse or be uncooperative.
Okay.
Thank you both for a terrific summary and a capsule of what's going on in the brain with dementia. Bob, you hit the nail on the head, I think, when you said that by the time people are diagnosed and are become symptomatic, the drugs really don't do very much. Amyloid starts accumulating in the brain when you're 20 or 30 years old. I mean,
That's correct.
It starts very early, and you can go 10, 20, 30 years sometimes without any symptoms. And there's no drugs for that. And there aren't any biomarkers that can identify people who have accumulating amyloid faster than, say, normal people who, the third of the people that are, the 50% of the people that get Alzheimer's. So do you see any progress whatsoever in being able to find biomarkers or diagnostic tests that are in development, because there aren't any now, where you can get this early and get an oral drug instead of an antibody, which is 10, 20 times more expensive than an antibody? Where's the progress on that? Has there been any recently?
You want to take it?
Unfortunately, I don't think that there really has been any specific progress. We do have. I mean, we have amyloid PET scans at this point. You can identify whether or not there is a presence of amyloid accumulation, and you might be able to quantify it. But at this point in time, we haven't scanned enough people to really know what normal is. So I think the first step is getting additional studies to actually quantify the amount of accumulated amyloid to try to create normal parameters, identify whether or not people who exceed those normal parameters are at a higher likelihood of developing Alzheimer's. I know that we do see that, and we've studied that to a certain degree in the brains of patients with Down syndrome who do develop amyloid plaque and neurofibrillary tangles at a much higher rate at a younger age than most other patients. So setting population standards is the first portion of it. But even if you are able to predict it, what are you going to do with that information? Are you going to start somebody on Aricept when they still have plenty of acetylcholine in their brain? You're just going to cause a lot of side effects. Are you going to start attempting to aggressively wash out the amyloid in the hopes that you never form tau tangles? There's not as far as we can tell, there's not a lot of evidence that that's actually going to happen, and the tau tangles may form normally regardless of whether or not there's amyloid plaque. So it gets a little bit complicated, unfortunately.
Yeah, it does. Unfortunately, I think the industry had concentrated very strongly on getting rid of amyloid for a long time and didn't look at other mechanisms. I just read about a biotech company called Anavex that is just announced that they're applying for a marketing authorization in the EU for a small molecule drug. I don't know too much about it. And there are a couple other small biotechs that are looking at different targets, and they're in various phases of development. But I think one of the problems is if you start so early, you're going to have a 10-year trial, and that's going to be really expensive. And do you see any way around that? I don't, sadly. No.
Can't say that I have a way around it either, unfortunately.
Well, thank you.
Okay, I think we're going to wrap up here. I just want to know how many people during Dr. Fitzpatrick's lecture did this? I
saw
did.
several of you, don't lie.
Yeah, I'm going to do it to you afterwards. I want to thank Dr. Fitzpatrick and, of course, our friend Dr. Altbaum, who's taking such good care of this community, really. They have been terrific. I'd like to give a special shout out to our pal, John Brandt. He's got a special program coming up called Music, the Soundtrack of Our Lives. and it's going to be presented right here at the Westport Library, December 12th at 7 p.m. It's going to be wonderful. I'm going to be here, that's for sure. I can't miss it. So thank you all so much for coming tonight. We hope that you're going to join us again next year for more fun and scary nights. Happy Thanksgiving.